welcome to our cardiovascular grand rounds from the DeBakey Heart and Vascular Center. I'm Dr. William Zoghbi, the Chief of Cardiology here at Houston Methodist, and it's a pleasure to welcome you for our academic year. And I think this academic year will feature amazing speakers from this country and from throughout the world to share the latest developments in cardiovascular disease. And I want to thank Dr. Kershaw Patel and Jennifer Collins and our audiovisual team for helping us broadcast these grand rounds. And we want it to be interactive. As you know, we have close to 120,000 followers on YouTube. This is an amazing engagement and sharing of knowledge with throughout the community of cardiovascular specialists and throughout the world. So this will be broadcast by live stream as well as YouTube. And if you have any questions, please send them along the line. You can text them to 37607 DeBakey. And I think this would be, hopefully, would be very interactive, throughout the year. And I think the curriculum for these grand rounds is really amazing, and you'll be very pleased with all the topics. A few other announcements that we have is we have multimodality imaging course coming up October 5 and 6, and also we have open aortic training October 24 and 25. Well, I was thinking of what to start with this year. And I usually cover either topics in medicine, trends in cardiology, or usually valvular heart disease. And this year is special in a way because this is the year where we have a multimodality imaging guideline from the American Society of Echocardiography and other associations. But interestingly enough for you is that we never covered prosthetic valve per se, not to my recollection, ever in grand rounds. And there is a reason for that, because used to be in the past, you have patients with prosthetic valves and you're an echocardiogram, and if you're happy with it, fine. If you're not happy with it, you do angiography or you go to the cardiac catheterization laboratory. And now we have so many multiple areas of imaging that the clinician has to navigate and say, when do I order something that I need further beyond a transthoracic echocardiogram? And so what I'm gonna share with you today is two things. One, some specifics for the cardiovascular imagers, but also important topics and navigation for the clinician. Now, the clinicians, including our surgeons, and I know Dr. Reardon, knows about echocardiography and other imaging probably more than our cardiology fellows. So the cardiovascular community is very well versed nowadays and should be very well versed in these prosthetic valves, because surgeons, although we would love them to repair valves, you're not going to be able to repair all of them. And even our new innovations are percutaneous techniques to replace the valves. So irrespective, you're going to be left with almost daily in a laboratory or in clinical practice to see patients with prosthetic valves. And this is, I think, an important issue to address, all of us collectively, and I think this is very timely. So what I have for you is, one, I'll share some interesting historical perspectives for you. We'll go through the types of the valves and what determines the valve hemodynamics. Approach to evaluating prosthetic valve function. I'm going to concentrate mostly on two valves because otherwise it will be quite packed. The aortic and the mitral valves, and try to understand the role of all these imaging modalities whenever you have an issue with a prosthesis that you have to develop. Now, you may or may not know that the first valve that was implanted was in the 1960s. So we're talking about 60-some years of a field. Before that, there was no prosthetic valve replacement. And this is Dr. Starr and Edwards. Dr. Starr is a cardiovascular surgeon. and you may or may not know that he's still alive. He's 98 years old in Oregon, and I had the chance, pleasure, and honor to meet him when I gave grand rounds more than 10 years ago in Oregon on prosthetic valves. Dr. Edwards, Lowell Edwards, actually was the brain behind inventing the first Star Edward valve that you could see here. I mean, it's intricate. Actually, each valve is handled individually and manually to make sure that its composition and its, structure is decent. Now, in 2007, the Lasker Award was given for two clinicians, Albert Starr, who you know, and Dr. Carpentier, Alain Carpentier, who in '68 put a bioprosthetic valve as opposed to a mechanical valve. And this is so they were awarded the Lasker Award, and you probably know the Lasker Award is a Lasker DeBakey Award because of their relationship of advocating for excellence at the national level. And I know you know more recently because of the work of transcatheter implantation that Dr. Alain Cribier was the first to implant the TAVI valve in 2002. And this is the picture of the first patient that he did, who almost miraculously got better, who was in bad heart failure, was almost dying. And 2 years ago, that was the celebration of the 20th anniversary of that procedure, TAVI procedure. That was a picture at the ACC where he was honored. In addition, obviously, he had major honors in France, etc. And he was an amazing gentleman. He has a history by itself that he survived a drowning episode and was in coma, and actually on the beach there was somebody who works in the ICU, had all the equipment that he had on the beach, and revived him. Unfortunately, Dr. Cribier passed away in February this year, and he was such an amazing gentleman. Now, I show this picture here because, do you know this gentleman? You probably don't know this gentleman. Well, this gentleman is actually the inventor of TAVI. Dr. Anderson, Henning Anderson from Denmark, who actually has the patent on the TAVI valve. And he built the prototype in 1989, 75 days after attending a symposium, a lecture in Arizona by Dr. Palmaz, Yulu Palmaz, as you know. And this is the publication that indeed within 75 days he had a prototype for the valve itself. And interestingly, in the bottom there, the picture of the gentleman between the fingers is that his father, who benefited from a TAVI procedure. So I think it's important, and he was honored, obviously, Dr. Anderson. He's less known, but I wanted to make sure that you know who the inventors are, and there were a lot of issues of how to get this commercialized, etc. But I think it's important to give credit to people who were inspired by a lecture and said that this could be feasible, and invented, this procedure, which nowadays has surpassed SAVR procedures in patients with aortic stenosis. So these are the various gamut of prosthetic valves that you may see. For the clinician, obviously, we need to know what kind of prosthetic valve do you have, so that we can understand, the longevity and so many other things and the complications that this, and including, the percutaneous valve procedures. Quite a few types, quite a few sizes, very different, quite complex. That's why I would ask all the clinicians to have this documented in the chart nowadays, because most patients have a card with them telling them what kind of prosthesis and what's the size of the prosthesis, I think, which would be really very important for future management, because you'll always have some issues when you put a prosthetic valve in a patient as opposed to a native valve. The choice of a prosthesis is indeed a balancing act. We're not going to go through this today because I want it to be much more focused on imaging and how do you evaluate them. But you have to incorporate the rate of structural failure, therefore the effective age and other comorbidities on the longevity, particularly of a bioprosthetic valve, inflammatory disease, end-stage renal disease, need for anticoagulation, and still required in a way of the traditional warfarin, physical activity, women of childbearing age, and as of late, more and more emphasis on patient preference. But remember, you are the recommending individual. You are the recommending physician, because while patients may have ideas of what they want to do, it may not be in their best interest. So you have to have an open discussion as to the pros and cons of whatever you're going to recommend for these patients. This is the first guideline. I was honored and privileged to share this first guideline, and this is what, 15 years ago. And at that time, the role of multimodality imaging was not even there, so it was all focused on echocardiography and what do you do with patients, etc. It has survived 15 years, and I was asked in to chair this document. Actually, a few of our physicians here, Dr. Little and others, Dr. Shamsi Pasha, were involved in writing these guidelines. And the difference, not that things have changed in a major way, but the major differences are, one, the percutaneous valves, and two, the ability and the importance of having multimodality imaging as advanced imaging when you are in need of further imaging beyond a transthoracic echocardiogram. In between, I also had the privilege and honor to chair this guideline, which is about percutaneous valves per se, and mostly emphasizing residual regurgitation in them. So these are the two guidelines that I would refer to you to understand and learn more about what we're talking about today. In structuring this, because you could go in many different directions, I wanted to share with you, some general considerations, and I think they are important when you evaluate such individuals. We look usually at two things. One, structure of the valve itself, its integrity, complications that you may have. So you have to look at mobility of the occluder in a mechanical valve or leaflet structure. Is there valvular degeneration already? And we know what the longevity is of bioprosthetic valves. Is there a complication of thrombus and pannus, which is more common in mechanical valves, but not unheard of in bioprosthetic valves? Endocarditis and associated complications. Where does these imaging modalities fit? Is there a role for PET in these situations? And last is the functional one, which also is very important. And I think that's where the first transthoracic echocardiogram is going to be important, because Doppler, this is where the Doppler velocities and gradients and measurement of effective orifice area occur. Is there a valvular regurgitation, and how much there is in regurgitation? So from an imaging point of view here, there are some of these valves, and you could see the imaging, so we're not going to belabor that point. One thing it's important for our trainees and physicians who may not know is that don't be fooled by the size that is about a prosthesis. The size is at the sewing ring and is not an internal diameter. So a 21 millimeter valve is not a 21 millimeter orifice to the valve, and usually it's about 2 millimeter, 3 millimeter, depending on what the thickness of that is. So when you measure effective orifice area by whatever methodology, it is dependent on hemodynamics and pressure gradients, pressure recovery, and so many other things. It is different than geometric area, and geometric area becomes very difficult when you have mechanical prosthesis as opposed to a biological prosthesis, where it's easier to measure the actual geometric orifice of that valve. Now, The clinicians, you may hear a murmur clinically. By Doppler or MRI, you will get a velocity across this valve. And what are the determinants of such? Valve size is very important, and that's why I re-emphasize the importance of valve size. 2 is valve type. You need to know what the type of this prosthesis is. Flow rate is crucial. If you have a hyperdynamic ventricle, you're going to have a higher velocity, higher gradient. And I would emphasize also that in every report that we share with the clinicians, that you have to put heart rate in your report, particularly when you look at mitral and tricuspid, because diastolic filling period is crucial as telling you what the mean velocity or what the mean gradient across this prosthesis, particularly if they come in either a very bradycardic could fool you, or a very tachycardic could fool you in the opposite direction. So let's take 3 kinds of these prostheses. 1, a homograft, if you will. 2, a biological bioprosthetic valve, and a mechanical bi-leaflet valve. If you look at the bottom of the cartoon that is in the guideline, there is a phenomenon called pressure drop and pressure recovery because of the velocity across these prostheses of any narrowing, if you will. So when you go through a bioprosthetic valve, you will have some increase in velocity, and most of the time the velocity is like 3 meters or 2.5 meters or so per second. So you'll have a pressure drop, and beyond that, the velocity decreases because the orifice is larger in the aorta, so you'll have pressure recovery. Interestingly enough, in a bi-leaflet valve, and it doesn't matter what kind of bi-leaflet valve, there is more of that phenomenon between the 2 leaflets that you have. And between the 2 leaflets, there is even a higher pressure drop and pressure recovery. And therefore, it really depends how you measure this, that you may overestimate what you get in hemodynamic situation when you go to the cardiac catheterization laboratory. Another thing that we know from Doppler is that if the aorta, particularly if you're talking about a smaller individual, if the aorta is less than 3 centimeters, you're going to have more of that pressure recovery phenomenon. So you'll have more discrepancy between the Doppler as well as the hemodynamic gradient. So it's important for the clinician taking care of patients to understand what these situations are. And if you want graphically what it looks like, here you go. This is the depiction that indeed the flow profile is not laminar, and between the 2 leaflets there will be a higher velocity. Can you discriminate between these 2 with Doppler? Most often not, and therefore you will overestimate what the actual gradient is. This is from early study by Dr. Baumgartner in Europe, looking at the St. Jude valve and the Starr-Edwards. I mean, we're not dealing with Starr-Edwards anymore nowadays, but in the St. Jude valve, you will have an overestimation of the gradients, and it is worse. The smaller the valve, 21 millimeter or lower, certainly particularly in a 19 millimeter valve, and therefore effective orifice area is less. Now, in the normal values that we share with you, all that is incorporated. So at least you have to go, and in the new guidelines, took some time to get every valve known to man with every size, everything else, and it's available for you. And we will have an app for this from the American Society of Echo and other societies for you to be able to navigate that when you have somebody with such. Now, for us to understand what the situation is, there are some parameters that you have to take a look at. One, clinically, it's always important when somebody comes in for a referral to know the date of valve replacement, type and size of the prosthesis, height and weight and body surface area. And body surface area is important, particularly when you talk about prosthesis mismatch with a patient. Symptoms and related clinical findings, blood pressure and heart rate, and we also mentioned already the importance of heart rate. And this is from the guideline. The first leg, the first bars there are the ones that I just mentioned. We image the valve as comprehensively as you can, taking a look at its structure, its complications, where it is, its mobility, in addition to the Doppler. We're not going to go through every little parameter here, I don't want to go through too much detail, but this is the importance of such when you evaluate a prosthetic valve. Now, where does advanced imaging fit in this situation? And advanced imaging, I'm talking about transesophageal, CT, MRI. We'll barely talk about PET in this situation because it has a little small niche in this situation, but this is what you're going to be faced if somebody tells you clinically, in addition to a first echocardiogram, that I need more information. And I think it's important for you. I'm going to go through it here, although in detail, but it's important for us to know the pros and cons of each one of these modalities. If you do a transesophageal echocardiogram, it probably has the best temporal resolution, close to spatial resolution, but certainly temporal resolution for you to be able to see that. Spatial is CT. Doppler hemodynamics of the valve function. This is the best technology for looking at hemodynamics. So keep that in mind if you're looking at gradients, et cetera, knowing that in a bi-leaflet valve, you're going to have an overestimation of these gradients. The best assessment is for the mitral valve because you're en face of the mitral valve, more than aortic, tricuspid, and certainly pulmonary. That's for transesophageal echocardiogram. Vegetations, it is the methodology for vegetation, particularly if this vegetation is small. Why? Because it is small and mobile. And the other technologies may not have that sensitivity. So if you're concerned about endocarditis of a prosthetic valve, this is your methodology, first methodology to do that. Identification of paravalvular complications, dehiscence, basically regurgitation. It is the most sensitive of all other modalities. When you hear about a CT scan looking at dehiscence, usually these are large dehiscences that you could see, but you're not going to be able to detect the regurgitation. So it's very important to keep that in mind. Obviously, it's portable. There's no renal dysfunction issues. You could do it in the ICUs, et cetera. So keep those in mind. Obviously, there are limitations. Optimal visualization depends on the valve type and the position. So if I'm dealing with an aortic valve prosthesis, particularly mechanical, I'm not going to be very happy. A mitral, you are en face, and we'll show you some pictures of that. Reverberations will cause shadowing. So from an imager point of view, I have to use transthoracic and TEE complementing each other to understand what the function or complications of the valve, and less feasibility in assessing, a pulmonary valve. CT has probably the best axial spatial resolution. And, it's important in this situation. Also, it's important that you could see the example on the left there is I can see a mechanical valve very well. So that's the beauty of CT is if I want to look at motion, occluder mobility, some of the issues. If you identify significant paravalve regurgitation, it is large usually. It's not a small one. And you could use non-contrast. If you're concerned about somebody with renal dysfunction, you could use non-contrast CT to take a look at mobility. It may not tell you about if I have a thrombus or a pannus formation, but at least you'll see mobility. Limitations, lack of hemodynamics. If you're interested in hemodynamics, you're not going to get it in CT. You may get it in MRI. You will get it in transesophageal and echo. Valve regurgitation severity is inferred from anatomic defect, and mild regurg may not be detected. Beam hardening could be an issue. Nephrotoxic agents, radiation, but in some of these patients, it depends on how important the question is and what you're looking at. So it's lesser of an issue, at least to me. For CMR, it is the other methodology. We have two methodologies that can tell you about velocity and gradients. So MRI and echocardiography. Better in bioprosthetic valves, where you can see you're going to have a lot of artifacts when you have a mechanical valve in MRI. Its main strength, regurgitation, if you're interested for whatever reason of the quantitation of regurgitation, I think it is probably a better methodology than many. So, and obviously ventricular function and everything else that you're talking about. It can identify valve abnormality in bioprosthetic valves. Again, large paravalvular regurgitation, dehiscence, or pseudoaneurysm. Its limitations are spatial and temporal resolution, artifacts we talked about, inability to detect small, highly mobile vegetations. Re-emphasize, endocarditis is echocardiography. And surface echocardiography, your detection is about 40%. So you have to go to a transesophageal methodology for you if endocarditis is a concern. And obviously, if you have an irregular rhythm or atrial fibrillation, if you're looking for quantitation, you may have some issues there. So that's, in general, how we look at this. And I want to delve into valve function and regurgitation, at least in the aortic and the mitral position. So this is a mechanical valve in the aortic position, and you have velocities almost up to 3. Is this normal or is this abnormal? How do we evaluate such? I'll share with you probably the first publication that was in circulation, a 2-author publication. Etchevizadeh, he was my medical student when I was attending at Bentab, and said, I have this thought. You want to work with me on it? I said, fine. And that's what you got. So I told you that, and he is a very prominent cardiologist in Austin. So if you're in Austin, you can call Ed. He's a great physician, cardiologist. But just imagine, since I told you before that the determinants of velocity and gradients is valve type and valve size. And in this, you have valve size and type, and notice the heterogeneity, the dispersion of the mean gradient, which will be the mean velocity and everything else, which tells you about the importance of flow and a particular patient fingerprinting, depending on the situation. So if it is so much flow dependent, then you try to get an effective orifice area, which decreases that variability. I'm not going to take it away because of errors and so many other things that you're talking about. And this is the same set of data. Now, you could say, my goodness, you have aortic valve in the 29 and 31 millimeter. And yes, we're a referral center for big aortas and big aortas. So, but you could see that the spread is much less, but the issue is dependence on valve size. So if I want to report an effective orifice area, I need to know what the size of the prosthesis is. And this is where we thought of, how can we simplify it further? So if I don't know what the valve size is, I still can tell what the function of this prosthesis is. And this is where the Doppler velocity index came in that same publication where we suggested it. It used to be called dimensionless index, which is basically an unknown, but at least it tells you that this is Doppler specific. It relates to the velocity. And basically, in a nutshell, is how much did this velocity increase going through the prosthesis? So this is your DVI, or Doppler velocity index. If it increases more than 4 times, which is a ratio of less than 0.25, usually you're in trouble. Most individuals, about 0.4 or so. For a TAVI valve, which is better hemodynamics, probably greater than 0.35, but there is more variability in TAVI than in a SAVR valve. And the reason for it is where you put your sample volume, at least the proximal velocity, which will change what this ratio is. So if you apply a Doppler velocity index, you take away the dependence as much as possible on valve size. And that's a good thing, because if I look at this Doppler velocity index, I may not know what the valve size is, and I'm less dependent on it. And usually it's about 0.4, certainly greater than 0.25. And in red are the ones that had to be operated on because of stenosis. So if we look at a prosthetic aortic valve, how can we tell that there is a obstruction? First, we always look at what the baseline echocardiogram is, but there are a few features that occur. One, ejection time, similar to the pulsus tardus, right? Is the ejection time gets longer, velocity is much higher, DVI is lower, mean gradient is higher. And another thing is an acceleration time, basically is the time that it takes from beginning of ejection to the maximal velocity. And usually it should be less than 80 milliseconds. Close to 100, you start getting concerned. You can take it to the bank if it is 130 milliseconds or more, that there is significant obstruction, in these valves. So what suggests stenosis is a high velocity 4, mean gradient of greater than 35, Doppler velocity index less than 0.25, effective orifice area less than 0.8, and an acceleration time greater than 100. We use most of these to at least come up and then compare it to a previous echocardiogram, and that's why the importance, and we'll emphasize again the importance of getting a baseline echocardiogram when somebody has a valve implanted, irrespective of which way you do the implantation. There's an entity that came, actually, Dr. Rahimtullah, late Dr. Rahimtullah mentioned that, is that if you have a prosthesis that is rather small for body surface area or for the demands of that body, that you're going to have a higher velocity, higher gradient, and it doesn't speak well for prognosis because you won't lose the hypertrophy that you've gotten before, and it increases basically morbidity and mortality down the line. So it is normal function for that valve, normal effective orifice area, and yet the gradients are high. And the definition you could see there, moderate, I would go for at least severe, 0.65 centimeter per meter squared. Notice that there is a correction for body mass index. And the reason for it is obesity does not necessarily impart an increase in cardiac output, demand for the body. So just imagine in the epidemic of obesity that we have in this country and beyond, if you just blindly divide by body surface area, you're going to get mismatch by definition on everybody. So at least in my book and in the recommendations, mismatch means high gradients to start with, high gradients, normal valve function, et cetera, and if you're concerned about it for an aortic prosthesis mechanical, you send them to a CT or fluoroscopy or whatever it is, and then you'll be able to see whether the function of that valve is good. And if somebody has a very high body surface area because of obesity, as opposed to true muscle mass, etc., please do not divide by such. So for the imagers, the echocardiographer, we always look at the contour of this jet through the aortic valve. We look at the Doppler velocity index, etc., and come up with some recommendations for you, the clinician, as to is there stenosis, is there a question? And not everything is black and white. You will have areas where you're really not sure, and it's up to the clinician to order further testing to figure out whether indeed there is a prosthetic valve dysfunction. Now, I mentioned earlier to you that the best visualization by an advanced echocardiography methodology, which is TEE, is in the mitral position. And the reason for it is the mitral valve is just en face to the transducer. You could see pretty much everything on that valve. You could see the ring, you could see the occluder devices, you could see everything that you need to do. On the right side, which is an aortic, is not en face, is from the side. And I'm sharing with you some of the nicer pictures. So what I'm telling you is this would not be my favorite second choice to get to an advanced imaging if I'm concerned about prosthesis mismatch or some dysfunction of the valve. So you could do a CT without an A or a CT with an A, depending on the situation is. I'm not saying don't use transesophageal at all, but need to know that you may have limitations And for the echocardiographer who's reading and doing the study, you have to be honest as to how well do you see the occluder device, opening and closing, and you cannot really tell about the angulation of this, going forward. Fluoroscopy has gotten out of favor, although it's rather simple, but there's still a skill and a technique to be able to see the valve well and see the opening and closing. And this is a CTA where you could see an obstructed thrombus. One is completely occluded, and the other one you can see a thrombus with it from either long axis or short axis. CMR, yes, you can use it if you're in trouble one way or another, particularly, and I would say almost solely, in bioprosthetic valve. In a mechanical valve, you have issues to take a look at, the occluder device and so many other things. So in a bioprosthetic valve, yes, you could determine gradients, you could measure areas if you can, and so this is for a surgical aortic replacement. Obviously, we live in the percutaneous world nowadays, TAVR and SAVR. There are some unique situations for TAVR compared to a surgically implanted valve. One is obviously the way it is. It's a long metallic frame as opposed to a very small annular dimension that a surgeon puts in, takes away the older valve, and puts in this valvular prosthesis. In general, it is better hemodynamically, and we notice that. Actually, the hemodynamics are phenomenal. DVI is higher, gradients are less, velocity is less. For the echocardiographer and others, the frame extends invariably into the LV outflow tract, and it affects the measurements of diameter for the echocardiography and others. And the last, actually, we will talk about is in regurgitation. If there is regurgitation, it is rather serpiginous. It's very difficult to see and therefore to evaluate the severity of regurgitation. This is for the echocardiographer and the clinician. This is a percutaneous valve. What is recommended is the measurement just before the valve itself, like in the upper outer to outer edge, with a pulse Doppler here in basically just before the valve. The velocities are different. If you go inside the valve, which often you're going to do maybe in the self-expanding valve, why? Because they go further into the LV outflow tract, the velocity will be higher. The Doppler velocity index will be higher, and that's why you see variability at times. That DVI could be 0.4 or could be even 0.9. In a 0.9, it means that I'm getting the velocity just before the valve itself, inside the frame, to through the frame. So for the clinician, if you see a lot of variability, most likely this is the reason for such. The one that has less variability is actual velocity and gradient through the prosthesis. So from our sonographers here and whoever's watching, you have to be consistent one way or another, so at least to give consistent numbers to the physicians. We always look for structural changes that occur over time, and these are in a bit arbitrary. Quite a bit of these data is by consensus as opposed to very solid data. However, if there is a progression in velocity or gradient or reduction in effective orifice area, DVI, you know your concern. So you always look for how much of these changes are, what really happened to hemodynamics. At times, heart becomes much more hyperdynamic for whatever reason, anemia, etc. Or gets depressed, so stroke volume goes down significantly because of a myocardial infarction or cardiomyopathy that has occurred. So be in tune to look at, not only look at the various components, because that's what will help you. And there is an entity called hypoattenuation leaflet thickening, or HALT, first described by Raj Makkar, I think in California, and basically diffuse thickening of the valve, and it's related to thrombosis. because it's reversible also. So take a look at this individual here. Stenosis, high gradient, and you could see these hypoechoic on CT. And after anticoagulation, pretty much gone, and the velocity is down to 2 meters per second as opposed to almost 3.5. And if you want to take a look at it in real time, take a look at how restrictive the motion was, and it's rather diffuse compared to what happened after anticoagulation. The recommendation is not to do a CT on everyone, but whenever you have a question regarding increase in velocity and gradient and effective orifice area, I think you would go for that just because it will change the approach to therapy in these patients. I cannot overemphasize to get a baseline echocardiogram after an implantation. People wonder whether it should be during the best hemodynamic situation, a few months down the line, particularly after SAVR, not after TAVR, because of hemodynamics are different. But we have to be practical at the same time. And the practical portion is the clinician needs to know what ventricular function is like after an implantation at surgery. And is there an effusion? What's the ventricular function like so I can modulate medications? And so pre-discharge, I think, is probably the way to go. The velocities probably would be higher than ultimately when they become down. Yes, you could repeat it 3-4 months down the line to get a good baseline, but I think you're not going to forego an echocardiogram prior to discharge in these individuals. In mitral valves, we use mean gradient, we use a pressure half-time formula, continuity equation. We always report heart rate because of the influence of such on mean gradient and heart rate. And then these are basically the numbers from the guidelines. Peak velocity, particularly in mechanical valves, should be below 1.9. 1.9 meters per second. We use a VTI ratio, which is the Doppler velocity index, but this is for mitral, effective orifice area, and pressure half-time. And remember, pressure half-time is a rather crude index of function. It will overestimate function if the valve is normal. It will overestimate area. So use it as an index, and whenever you get concerned, use a continuity equation to come up with a valve area. And this is an example for you, a very high mean gradient of 22 at a decent heart rate. And you could see the dysfunction of these, motion of the prosthesis. You could see one of them is completely occluded. You could see that very nicely on 3D in addition to the 2D examination, and the other is barely opening. You could use these for valve in valve, right? So this is a great example of a high mean gradient to start with, a visualization from the atrial or from the ventricular approach, and after putting a valve in valve, the motion of the valve is nice and the gradient is way down. For the clinician as well as the echocardiographer, be careful about when things don't make sense. This is a patient with a mean gradient of 8. Most people with a prosthetic valve, be it mechanical or bioprosthetic in the mitral position, should be about 5 or so at a decent heart rate. So if the mean gradient is high and the pressure half-time tells you, oh, it's most likely normal, be careful, because actually the area, if you use the continuity equation, is much reduced, and indeed this patient has issues. So be careful when the data is really not concordant. So you have to use, your judgment, be it as a clinician or as an imager, echocardiographer, to do that. Effective orifice area, as opposed to pressure half-time, cannot be used if you have significant regurgitation that's concomitant. It works best in regular rhythm, because otherwise you're gonna try to, match a certain beat with another beat. So in atrial fibrillation, you have to be very careful as what to match, etc. So these are details for the echocardiographers for them to be able to see and how to navigate this situation. This is a point that you don't have to belabor too much. Mitral valve is really best seen by transesophageal echocardiography. So if we look at comparative strength, and Believe it or not, it took about 6 months to get this part of this table, to get consensus among all the imagers. So if we look at valve function and stenosis, valve structure, okay, motion and mechanical. Valve structure probably best with TE and CT. Valve structure, motion, mechanical, best by CT. In the mitral position, it is good. In the other positions, may not be as good by transesophageal echocardiography. Hemodynamics usually are best with echocardiography and transthoracic approach. Thrombus pannus, particularly mechanical in CT, a little less than transesophageal echocardiography. So hopefully that will guide you one way or another in what to order after. How about regurgitation? Regurgitation, each one of these valves has a built-in regurgitation, particularly in mechanical prosthesis and bioprosthesis. The regurgitation is very mild and usually, it's trivial. Echocardiography, you need to remember, if you're the ordering physician, that we have an issue in mechanical valves in the mitral position. If you have shadowing, just like you see here, you're not going to be able to see imaging-wise, and you're not going to be able to detect with Doppler. As opposed to an aortic position where it is not hiding behind the prosthesis itself. So we have issues in detection of significant mitral regurgitation in mechanical prosthesis, and this is such an example for you. It's very hard to tell, even for our experts, of how much regurgitation there is. And actually, if you go to transesophageal echocardiography, you see a major dehiscence of this valve and severe regurgitation. So it's important for the clinician to keep that in mind, and it's important for the echocardiographer to keep that in mind, because you have to have some indices to tell the clinician, there may be a problem and you need more. One, if the E velocity is high. If the mean gradient is high, I'm not talking about 10, 20. We're talking about 6, 7, 8, because the valve is not obstructed, it's just high flow through the valve. Elevated ratio, a DVI ratio greater than 2.2. Good LV function, but low systemic output and pulmonary hypertension. These are the things that would come to mind. Doppler velocity index for the mitral is the inverse, and you can blame yours truly on that, as opposed to the same ratio. And the reason for it is that ratio will become in 0 point almost 0, and it just doesn't make much sense. 2 is that this ratio of the velocity through the mitral prosthesis and what goes out works for both regurgitation as well as stenosis. So it's an index of valve function as we go along, and should be, usually less than 2.2, and this is such an example here for you. You could see this valve dehiscence. You cannot see much on color, right? Similar to the previous example. And the Doppler velocity index in this situation is very high, as 2.7. And if you take a look at this valve itself, it is rocking in a major way and dehisced in a major way to give significant regurgitation. And on 3D, you will see that this valve is really dehisced in a major way all the way, and it opens up, that dehiscence opens up in systole every time the heart contracts. So clinical suspicion for MR should be high, particularly that we may miss significantly, and a transesophageal echocardiogram should be indicated whenever you have an issue with such. And these are the guidelines. We're not going to belabor that point of how do you evaluate significance. In an aortic position, usually much lesser of an issue, again because you don't have much shadowing that can occur, and you can see the regurgitation. The criteria are similar to native valve, but you have to be aware that most often, particularly in mechanical prosthesis, the regurgitation is very eccentric, which puts a lot of problem to Doppler, color Doppler. Why? Because you may not be able to assess severity as much, but you have to use other criteria. And where transesophageal echocardiography would help in the identification of the etiology and the complications of such. And this, as you could see there, a paravalvular regurgitation and also a small abscess in the mitral intervalvular fibrosa. Now, we mentioned that for a TAVR valve as opposed to a SAVR valve, we have more issues in identifying the aortic regurgitation. And why? Because you could have multiple areas of regurgitation in this valve. If you take a look at this valve here, there are a few in this area here, much larger here in this area. So if you do a regular echocardiogram tomography, at times you may not see anything. So you have to go to the tangential area to start seeing some regurgitation, and it will be very hard to quantify. So how do you quantify regurgitation in this situation? You take a look at the vena contracta, which is the area of what you're seeing here, and you try to understand what the situation here, in addition to volumetric. So if you're in the catheterization laboratory, you're going to need more than an echocardiogram. And I know, the implanters will times use an aortic root injection, look at pressure differences. Nowadays, with modifications of the skirt, we have lesser of an issue than in the earlier models of a TAVR. But I think this is an issue here that you have to keep that in mind. And because of the eccentricity, it can fool you as to what the significance of that. So we use two criteria for color Doppler. One is the vena contracta area, and the other is how much of the circumference this regurgitation is affecting, the area of the valve itself. So the circumference, if it is greater than 30%, you're dealing with severe regurgitation. Somewhere in the low 20s or teens, it's probably moderate. But again, you have to put it together with some volumetric data for you to be able to understand the severity of the regurgitation. And in doubt, you do a quantitative method like cardiac MRI for you to be able to see how much regurgitation and quantitate how much regurgitation there is. And you could see that here in a nice example of aortic regurgitation after valve implantation. CT, I think in these is important to identify the anatomy and the complications that occur in such valves. Here you have an abscess and pseudoaneurysm formation seen both by TEE and CT, and I think in CT it will give you a much larger field of view for the surgeon to understand where to go and how extensive it is. Yes, you can detect it with TE, but you may not be able to have a full visualization in 3D as to what the situation is. PET is usually reserved for difficult clinical situations to diagnose active endocarditis. If there is no obvious vegetation on transesophageal echocardiography, persistent fever after prolonged antibiotic course, etc., and the better specificity is performed is at least 3 months after valve replacement, because there's still inflammation after early valve implantation. So a positive test early on may not tell you actually that there is an active infection as opposed to inflammation. So in valve regurgitation, how do these methodologies compare? In valve regurgitation, take a look at the transthoracic approach, the first one. I think it's decent overall, but most often you're going to need more to try to understand the mechanism, the etiology, and if there is endocarditis. So transesophageal actually stacks up very nicely as to localization of where the regurgitation is there valve dehiscence? Endocarditis is still the first diagnostic methodology, and quantitation. CT does not work as well here unless you're looking at valve dehiscence and major complications, just like I showed you there. MRI, its major advantage is in quantitation of regurgitation, if this is important for you to understand what the quantitation is, how much is the severity of regurgitation in this valve. So this is actually the table from the guideline that we put together, both for valve function on top and stenosis, and valve regurgitation at the bottom. So in conclusion, in a summary of what I shared with you today, One is clinical evaluation. You need to know the valve type, size, and when the valve was implanted. A baseline echocardiogram with Doppler study after surgery is truly a must, surgery or implantation, whichever way. A transthoracic and Doppler evaluation of structure and function is indeed the first-line diagnostic methodology. Its main limitation, mitral valve regurgitation, particularly in mechanical valves. Now, the other advanced modalities, they are very important in your diagnosis and management. They complement each other, but please don't stack them all together, right? Be selective as to what is the clinical issue, what is that you want to solve, so you can aim for that particular modality. TE impact depends on valve type and position, different than MRI and CT, okay? The pros and cons. We talked about the mitral valve. CT is particularly helpful in assessing valve anatomy and structural complications, while CMR provide hemodynamic evaluation, particularly in regurgitation. And in case you're dealing with high gradients and suspected stenosis or regurgitation, compare with previous studies. Use X-ray for mechanical aortic valve, stenosis or prosthesis mismatch. Fluoroscopy, CT with or without angiography is usually better than transesophageal. Transesophageal for other valves with the major impact in mitral and the least impact in pulmonic. CT in selected cases of significant complications, planning interventions, be it percutaneous or surgical. CMR in some cases of prosthetic regurgitation, particularly when quantification is important. And if you want to know more, come and join us in 3 weeks. We have our 13th annual multimodality imaging course. It is hybrid. We would love to share that with you, be it in the United States or if you're globally, wherever you are. All the course will be taped, will be available for you for 2 months afterwards. But for the audience here, we need you in person. Thank you very much for your attention. Questions?
So Bill, thanks for another great lecture. So most of what we as interventionists will look at is anatomy and physiology. And that was almost all what you talked about, except you got the PET scan. Now, people are doing really interesting things with PET scans besides endocarditis, not only looking at the thin layers of thrombus, but metabolic changes in biologic valves that may lead to calcification. I have 2 questions. One, what are we doing here in the way of looking at metabolic changes in biologic valves? And number 2 is about Doppler velocity index. I love Doppler velocity index of the aortic valve because it represents a ratio of that patient's aortic valve area to that patient's LVOT. So I have a physical picture in my head of what it means. What does the Doppler velocity index of the mitral valve actually represent?
All right, two important questions. I don't know if Dr. Almala is still here or not. I know he had to go for a conference. I know we did a lot of work in native valves, particularly aortic valve, for inflammation and progression and prognosis. I don't know if he's working on the prosthetic valves, be it percutaneous or implanted valves. I'm pretty sure there is a role. The question is, if you detect it, are you going to be able to do something about it to decrease or delay the progression? Because ultimately, what impacts your intervention is significant stenosis or regurgitation or a combination of both. The question is, can we, with some anti-inflammatory agents, if the issue is predominantly inflammation as opposed to wear and tear, I think these are very important for us to study, and I don't know if he's actively studying that, yes or no. The other question is, what does the Doppler velocity index for the mitral do? Think of the Doppler velocity index of the mitral as an index of valve function. Function meaning stenosis or regurgitation. The difference between an aortic and a mitral. In the aortic is I'm only looking at what is the acceleration, how much did the velocity increase from one position just before the valve to through the valve. And if it is narrow, the DVI will go down significantly. If there is regurgitation, it should not influence it much because the flow is higher before and through the prosthesis. In the mitral position, since you're looking at two different areas, the mitral and the LV outflow tract, what you're looking for is, one, can I detect regurgitation because flow through the mitral valve is much higher, and at the same time, flow through the LV outflow tract is much lower. So it increases the ratio. Okay? In stenosis, the velocity through the valve is higher. LVOT velocity is normal. The ratio is high. So whenever the ratio is high in a mitral prosthesis Doppler velocity index, it raises a question. Is this stenosis or is this regurgitation? And you have to figure it out. Yes, Steve.
Masterful as expected.
So you alluded to all the changes, the TAVI and some edge-to-edge repair stuff that's coming, that's here, sorry. But the transcatheter mitral valve implant work, the transcatheter tricuspid valve stuff, these are different valves. They're bigger, they're bulkier, they have subannular fixation. They have stuff that we're still trying to figure out what's what's normal? What's the normal velocity? What's the normal flow profile? The normals are unknown, the abnormals are unknown. So the first question is, do you have the energy to rewrite these guidelines? in maybe 3 to 4 years, because it's...
I like the time frame of 15 years that we did.
15 years, I don't think we can wait 15 years, because the second question is, how does...
No, I mean, on the mitral, we don't have, and in these guidelines, we did not address investigational valves, right? So at that time, now you have you have a clinically approved tricuspid valve, right? But these normals are going to go up gradually over time, and hopefully you'll have some approval for the mitral. Go ahead, sorry.
Well, that's what the second question is. So the tricuspid is approved.
Mitral, probably, we don't know yet, but probably soon. The cable valves are not technically intracardiac, but they matter. They're going to come eventually. So how does an imager stay up to speed with this rapid technological advance in valve work? What are your recommendations?
And I do hope that the professional societies will come with updates. This document is 62 printed pages. It took us 2.5 years to put it together. A lot of work, but I think the vast majority will stay the same. The principles are not changing. So what will change, I would presume, is the newer valves that will be in the mitral and in the tricuspid position. In the 2019 guideline for percutaneous valves, we addressed regurgitation for mitral and tricuspid and all the others. So where I see the changes would be some normals and cautions or et cetera regarding the newer approved. In this document, there are data for valve in valve. So at least the normals, valve in valves for whatever is available is there. And over time you'll have more data, but I think the general principles of how do you evaluate will stay the same in a way. You may have more data that supports, and this is the first really that looks at multimodality imaging and where do they fit, because we didn't have really anything regarding that to guide the clinician. Any other questions?
Well, Dr. Zoghbi, you've seen almost anything and everything in the valve evolution that is happening. Your thoughts on the next evolution, possibly with AI. How do we get that incorporated into our regular valve imaging or in general in imaging? What would be your message to the next generation? Because there's so much to learn about flow, sizes, structure, identification of the patient, maybe in the whole radiomics, a lot of the things that we haven't even yet put inside. Where do you think this field evolving in this area?
AI will be in every facet of life, including prosthetic valves. And it's not will be, it is already here. And it will evolve. I think this is the next generation of cardiologists. It will be part of what you do every day. In a way, it's part of what we do nowadays because, at least in echocardiography, AI is already incorporated in acquisition. How do you optimize acquisition? AI will be incorporated in how do you have a preliminary interpretation of an echocardiogram, be it prosthetic valves or the like. AI ultimately will be incorporated from a patient management and prognosis because you will marry this with clinical events down the line because you and I may not think, we may think about the prosthetic valve per se, but you don't think about how much remodeling is there or no remodeling for the ventricle and therefore a bad outcome down the line, what the pressures are, so many other things. So we have so many parameters that the human intelligence may not be able to put it together, but the human intelligence is crucial to overlook the artificial intelligence. All right, well, thank you very much for attending. Look forward to a great academic year ahead.
Congratulations. Excellent, very comprehensive.